Okay, well, welcome everybody. As Chris said, this is our Hope Zoom call, and we have a special guest today, Dr. Sean Dineen from Moffitt Cancer Center in Tampa, Florida. And we're excited about getting into his presentation. Before we do that, Chris will give some of our typical disclaimers and other information about PMP PALS.
Thank you, Adele. And give me just a moment while I get that pulled together. And I'll share my screen. Good morning, everyone.
Good morning.
So just going through the disclaimers real fast, just some brief reminders. Although we have experience with the disease, we are not licensed physicians. It's vital that you have a licensed physician on your team. So we're not qualified to provide medical advice, but we'll guide you as best we can. In physician presentations, there can often be data that might be scary or images that can be scary. So please be aware of that. And while we try and keep this an anonymous form, we cannot guarantee that. So we do our best. You can change your name in Zoom, and you're not obligated to speak if you don't want to. And actually today, because it's such a large group, we will be muting everybody. And we will be sharing the videos afterwards too. So your likeness will be shared with the public. But we're super glad you're here and incredibly excited to have Dr. Dineen here with us.
Okay, thanks, Chris. As I mentioned, we really are privileged to have Dr. Sean Dineen join us. He is certainly one of the specialists that we speak so highly of. Dr. Dineen, does specialize in, treating PMP and other peritoneal diseases with cytoreductive surgery and HIPEC. And, we've had the pleasure of getting to know Dr. Dineen these past few years at an advanced cancer therapies conference sponsored by the Society of Surgical Oncology. And he's been, very supportive and interested in doing what he can for our patient community. One quick story just to show you how caring he is. When we were at the conference this past February, it happened to be in Orlando, and one of the employees of the hotel there had a relative that was recently diagnosed, and the SSO folks put us in touch with her, and Chris and I just happened to be sitting there talking to her and her sister-in-law. Dr. Dineen walked by and was just gracious enough to provide some information. So much appreciated. So again, with that, welcome everybody, and I'm going to turn it over to Dr. Dineen, who's going to present on the really research related to repeat CRS and HIPEC.
Hello, thank you for the introduction. So as was mentioned, I work at Moffitt Cancer Center. I've been here in Tampa for about 3 years now. And my practice here has really focused very quickly on treating almost exclusively patients with peritoneal disease. As would be typical, about half of those patients are patients with appendix cancer or PMP. And we'll get to the slides, I guess, here in a sec. But I will say, I have at least a moderate amount of experience giving talks, and have gotten fairly comfortable with public speaking. I will say I'm fairly nervous speaking to this many patients. So there's I guess a different feeling now that I'm with this audience. So hopefully I'll still be able to move through this relatively smoothly. So we will talk. Yeah, there we go. So we were having a minor technical issue, so I'm going to have Chris advance the slides for us, but I think that'll work. So we can do the next slide. All right, so my disclosures, I don't have any financially relevant disclosures or interests related to this talk. Intraperitoneal chemotherapy, or HIPEC, is frequently considered off-label use depending on the drug. So that's an FDA disclosure there. The next disclosure is been mentioned. This is a general discussion, not specific medical recommendations. And then the final disclosure, which is specific to Zoom. I am at home, and so there may be some kids in the background, possibly even one running in and out here for a few minutes. So sorry about that if it's an interruption. So I thought we would review a little bit about appendix cancer today. I'm sure almost everybody is familiar with it, but we'll make sure that we kind of have a background. We'll talk a little bit about the role of repeat cytoreductive surgery in HIPEC, focusing on a paper that our group has put out recently. And then I thought we'd have some time to discuss future directions, what questions are important to this group for us to answer in kind of a patient-centered approach. And then at the end, if there's anything else people want to discuss, I'm happy to. So next slide there. So appendix cancer, as y'all have probably heard, is relatively rare. If you take the incidence from appendectomy, about 1% of all appendectomy specimens will contain a neoplasm. Around 50% of those are neuroendocrine tumors and about 50% are adenocarcinoma. That number continues to sort of increase from the adenocarcinoma or the non-neuroendocrine tumor side. And then there's a breakdown within adenocarcinoma of the mucinous epithelial neoplasms. And those would be the low-grade appendiceal mucinous neoplasms, the high-grade mucinous neoplasms, and then mucinous adenocarcinoma. Mucinous adenocarcinomas will also have typically a three-tiered system in terms of low, so well-differentiated, moderately differentiated, and poorly differentiated. And we'll show a slide or two on that. The terminology can be very difficult and has been evolving really for longer than I've been practicing. The terms have been changing. So it can be kind of hard, especially if you're looking back at studies from even 10 years ago. They're going to be using different terms or different abbreviations than what we would use now. So that's hard. It's also hard for many of us because there is histology related to the appendix, which is the primary tumor, as well as the peritoneal disease or the PMP. And sometimes those are discordant. And so that can make it very hard sometimes to figure this out. I think we'll be able to simplify it a little bit, and we'll just talk mostly about low-grade and high-grade tumors. That I think helps a little bit. Next slide. So the histologic considerations we were just kind of mentioning. So especially when we're looking at the grade of the peritoneal disease, that can range from acellular mucin, which is the lowest grade, and that's essentially just mucin that has spilled outside of the appendix. And then low-grade PMP, which is based on the amount of cellularity within it. High-grade PMP, which would be a higher concentration of epithelial cells, and then signet ring cell PMP, which is the presence of signet ring cells. That's a diagnosis that's made under the microscope, and the characteristics of the cell looks like someone has pushed a signet ring into it, and that's something that the pathologist can tell you. When we talk about the extent of disease, that's when we talk about scoring systems. PCI is probably the most commonly used one. That's the peritoneal carcinomatosis index. I have a slide that breaks that down, but essentially that's a score from 0 to 39, with the higher number indicating more extensive disease. And then we won't talk a lot about tumor markers today unless someone brings up a question, but tumor markers are also part of kind of our initial workup and can help us to determine, in some instances, the aggressiveness of the disease, with elevated tumor markers representing more invasive disease in most instances. Next slide. All right, so just a couple of slides to just point out the importance of tumor grade. So the figure on the left there is from really a seminal paper with respect to PMP, and that gets into the differences in terminology. So this paper from 2012 uses a terminology that we've kind of moved away from. But essentially those top two lines, the blue line and the gold line, would represent what we would call low-grade disease right now. And so you can look at this. This is a curve of overall survival. In the patients that have lower grade disease do better than those with higher grade disease. And then the figure over there on the right from 2017, this was published by a colleague of mine from MD Anderson. And you can see this is patients with mucinous adenocarcinoma. And if you break that down into sort of the well, the moderate, and the poorly differentiated cancers, you can see the difference in survival really kind of goes in that three-tiered type system. So when you are talking about appendix cancers, it's important to understand this, because if you're grouping together all of the different types of histology, when you're asking a question about survival, you have to make sure that groups are balanced, so that one group doesn't contain more poorly differentiated cancers or less. And so it can become very important when you're trying to make those types of comparisons. Surgical outcomes should not be that different. So if you're just talking about, how long an operation takes, sometimes you can group everybody together. So it's important when you're trying to tease out data from studies to know what the composition of each of these different histologies was. Next slide. Next slide. All right, so this is that PCI score that I was talking about. This is from, actually, those are the papers that I took this from, but the scoring system's been around for longer than that. And essentially on the left, you see that the abdomen is broken down into 9 different regions. And then the small intestine is broken down into 4 different regions. Each of those gets a score based on the size of tumor that's present there. And that's over there on the top right. And so when you are doing your exploration, you outline kind of where each of the regions are, and you come up with a score from 0 to 39. Tumors that are bigger than 5 millimeters in size, up to 5 millimeters in size, you get a score of 1. Between 5 millimeters and 5 centimeters, you get a score of 2, and then greater than 5 centimeters, or when you just see a confluence, so the entire area, the peritoneum, is covered with tumor, then you would get a 3 for that. Next slide. And then the last thing to talk about is the completeness of resection. And so typically we'll use a scoring system called the completeness of cytoreduction score, or the CCR score. And this really quantifies the extent of residual disease that's present when the cytoreduction is done. And so we'll talk about HIPEC surgery, but many of you probably know the sort of more technical term is cytoreductive surgery in HIPEC. And really the operation of removing all of the tumor is the cytoreduction. And that's a really critical part and really the time-consuming part of the operation. If we're done and we see no visible evidence of residual tumor, that's a CC0 or CCR0. If we see tumors that are less than 2 millimeters in size, that's considered a CC1. The rationale the rationale for using that 2.5 millimeter as the cutoff is based on some studies that looked at how deep does the HIPEC penetrate into a tumor. And it's somewhere around 2 to 3 millimeters in size. And so the thought is that if you have tumor that's less than that, the HIPEC, the intraperitoneal chemotherapy, should penetrate into that and treat that. And so that's how we have come up with that. When you leave tumor greater than 2 millimeters in size, but less than 2.5 centimeters, that's a 2, or sometimes called a maximal debulking. And then when you leave tumors bigger than 2.5 centimeters, that's considered a CC3 resection. So I think if you hit the next slide, sorry, that's fine, you can stay there, but we'll typically consider a CC0 or a CC1 a complete resection. Sometimes we'll split those out, but this slide here shows, I think, that point well, that CC0, CC1 have pretty similar survival. This is overall survival graphed over months. And so in general, we will consider 0 and 1 as a complete resection. And sometimes for the purposes of comparison, we'll group those together. So we'll compare 0s and 1s to 2s and 3s as is done here. So this was, so the first one was from, again, that paper from 2012. And just to kind of drive the point home a little bit more, this is 2 additional studies, the one on the left from Washington, D.C., and the one on the right from the Wake Forest group. And again, you can see that the fairly wide split in the curves demonstrates the importance of being able to achieve a complete cytoreduction. Next slide. So it would be nice if we had a way to predict who was likely to have a complete cytoreduction before surgery. So one of the studies that I did when I was a fellow was to look at the experience from MD Anderson. And we identified 5 areas that we could see tumor preoperatively that we felt that was associated with an incomplete cytoreduction. And so, those areas we identified as liver deformity, deformity around the spleen, disease posterior to the portal vein or around the anterior pancreatic border, and then what we called cauliflowering of the bowel or small bowel mesenteric foreshortening. And the next slide, I think, shows some pictures of this. So the top 2 there, A and B, show what is PMP, and I think I don't have my pointer. So so on the top there, A, you can see the dark gray around the outline of the liver. So that's mucin above the liver. Right there, the cursor's on the spleen, and that's some mucin air around the spleen. That's relatively normal in appearance, and there's not what we call scalloping or kind of a jagged edge to the border there. B shows, again, some mucin around the liver and the spleen without scalloping. It shows the portal vein, which is essentially right in the middle of that screen, without tumor. And so that that's not normal because of the presence of mucin there, but that would not score any points on the system that we were developing. Whereas if we look at the bottom row, and we've got some blue arrows there pointing out the scalloping of the liver on C. On D, you can see the sort of bottom left arrow, again, shows the scalloping of the liver. The next arrow over shows the disease around the portal vein. That's that dark gray there that's surrounding the white structure, which is the portal vein. The arrow on the bottom right shows scalloping of the spleen. Similarly, that far right arrow shows some more scalloping of the spleen. E shows where the arrow is some disease over the pancreas. And this is just a way to use the preoperative CAT scan to assess what the likelihood of a complete cytoreduction is. So we can go next slide. So for our study at Anderson, we took a cohort of about 28 cases that compared to a cohort from the National Cancer Institute. We found that a score of 3 or more was associated with an incomplete cytoreduction in 28 out of 28 cases. So we knew that if we went through the CAT scan preoperatively and you had a score of 3 or more, that we could counsel those patients that we may not be able to get a complete cytoreduction. And that would not necessarily preclude surgery, but it would help us to set the expectations prior to what is an invasive operation. Next slide. There was a study that came out, though, about 2018, I think, that questioned the usefulness of this scoring system because the sensitivity was somewhat low. But in that study, they still showed that the negative predictive value was still 90%, meaning you could still identify the patients that were unlikely to get a complete cytoreduction 90% of the time. So I think if we go to the next slide, there was another study around the same time. This was out of France that was trying to look at this question. They came up with a different scoring system, the SRS score, which was a more, a little bit more quantitative system to look at the measurements of how thick the tumor was in certain areas that are listed there. I'll probably skip all of those details, but essentially looking at the measurement of how thick the tumor is at different points, mostly around the liver, to get a sense of whether or not the patient was likely to have a complete cytoreduction. So if we go to the next slide, what we did at Moffitt was we wanted to look at both of those scoring systems, the one that I had developed at MD Anderson, as well as that SRS system, to see if we used a separate set of patients, if we could validate that. So we looked at 23 patients, 13 had an incomplete cytoreduction, 11 had a complete cytoreduction. And I think if we hit the next slide, what we showed, if you look at the table 4 in that top box, the SRS score less than 28, which is essentially when you add up all of these components, if it's less than 28 millimeters, there was a positive predictive value of about 75%. And then if you look at the line down from that, in the patients that had more extensive disease, so a score of 28 or more, you could predict an incomplete cytoreduction 83% of the time. And then if you look down at the next, the SPAT score, which was the simplified preoperative assessment of appendiceal tumor score from MD Anderson, we again showed that the negative predictive value, that bottom right number, was almost 90%. So again, I think that if you go back up just one there, Chris, that the scores aren't used to decide who can and cannot have surgery. And sometimes I think that's misinterpreted. But I think that it is helpful to review something like this as a way to determine what the expectations are. And then just that bottom number shows that the higher that your score on either of these scoring systems, it is correlated with a higher PCI score. So there's some validity to these scores as an assessment of the extent of disease. All right, next slide. So that was a little background. I took out some of the pictures that I normally show just to make it a little bit more accessible to everybody. If anyone is really kind of feels like they didn't get the full experience of a surgical talk, I can always show some pictures later if we really feel that need. But I think with that background, that can set us up for our discussion about when to consider repeat HIPEC or why we would do that. So I guess I'll take maybe a short break to see if there's any questions we should answer now before we jump into this.
Yeah, and I meant to mention, please send your questions to Zoom at pmppals.net if you do have questions. Or if it's super urgent, wave your hand and we can work through it that way. Oops, Rita, did you have a question? Or sorry, Orna?
Muted. She's muted.
Yeah.
Chris,
Hey, Chris, can you unmute Orna?
One moment. There we go. There you go.
There. Orna?
I would like to go quickly to the tumor markers because all specialists are doing the same. Some control blood of all these 3 markers we just saw now, and some of them only the CEA. What's why? I mean, how important are the CA 19.9 and the CA 125 if they're not controlled by all specialists?
Yeah, that's a great question. So I think that most providers would check a CEA. I think that's going to be the most commonly elevated and the most commonly useful. I think that the use of CA 19.9 would probably be the second most common, and then CA 125 would be the third most common. The decision about checking all three is typically, at least in I would say in my practice and in many practices, any of those three can be elevated, and if so, can sometimes provide insight. There are reasonable studies that kind of look at the correlation between an elevation in 1, 2, or 3 of those markers with the invasiveness of disease. Meaning if all 3 are elevated, that correlates to a more invasive disease pattern than if only 1 is. The other use for those is that if they start out high and then you have surgery or some other intervention and they drop, that's a marker of the usefulness of the intervention. So by checking all 3, you may identify that one of those is elevated and the others are not, and then you can really focus on the one that was elevated as the one that you would follow.
And Dr. Dineen, for PNP patients, can you give a guesstimate or from your clinical practice, what % of patients do show on blood markers, any one of the 3?
Well, yeah, so it'll be around 50%, but I think that's also a good example of when you have to kind of define that patient population. So if you're looking at mostly higher grade patients, then that number will be higher. So higher grade patients will have elevated tumor markers more often, but I would say around 50% of the time if you take all comers.
Makes sense.
So if a patient only gets surveyed with one of the 3 and that's elevated, would the next step be to try to get a picture of the other 2 so that all 3 present a more complete picture?
I would. I mean, again, my practice is to check all 3 and to follow all 3. I think it's reasonable if you have had all 3 checked, and some groups may even check. There's a 4th one that I think is less commonly used, a CA 15.3. So I think that my practice is to check all 3 and to follow all 3. At some groups, you'll check all 3. If they're normal, then maybe you don't follow all 3. Or if only one is elevated, then you would just only follow that one.
I see.
If you've seen someone and only one is checked, I mean, I think it's reasonable to ask to have the others checked, though. Depending sort of on where you're at within your treatment plan, it may not have a huge impact on what's done. So I think of the tumor markers as a piece of information, something that can be helpful to make decisions preoperatively, something that can be helpful when you're in surveillance, but just sort of one piece of the whole workup.
Thank you. Cheryl, did you have a question? Oops. Working on getting you off mute.
So thank you. You showed the graph on longevity related to cytoreductive score, with those having a cytoreductive score of 0 or 1 doing really well. Is that irrespective of pathology? The reason I ask is I'm signet cell undifferentiated, but I did have a cytoreductive score of 0. So yeah, I'm just interested in your thoughts on how that's related.
Great question. So those slides, the first one I showed was mostly patients with low-grade disease, and so that survival is going to be skewed towards the high side. I think your question really highlights the difficulty of comparing survival data across studies. So when you're talking about survival, especially, you really want to make sure that you understand the histology, just like what you said. So, so the specifics, meaning survival on average of 1 year versus 5 years versus 10 years, is going to be very dependent on the the pathology, the grade. But within each group, so within a well-differentiated or within a moderately differentiated or poorly differentiated, those patients that have a complete cytoreduction will do better than those that do not. So the completeness of cytoreduction will still be an important prognostic factor, but what the actual survival is will be very different. So in the poorly differentiated group, it could be a difference of 6 months versus 18 months, whereas in the well-differentiated group, it's just a more indolent disease. So, so the survival is always going to be a little bit higher.
We did have a question come in, and I'll read it. The question is it common for tumor markers to be normal, but inflammatory markers elevated? So in this case, inflammatory markers were elevated, but tumor markers were fine, and the laparoscopy showed the need for a total hysterectomy.
So that's an interesting question, because so I don't know the answer to that question. The reverse can be true though, whereas tumor markers can be elevated due to inflammation. So if you're either recently post-op from some procedure, or if you've had an infection, for example, you can see an elevation in your tumor markers. It's really just a marker of peritoneal irritation or peritoneal inflammation. So, for example, I don't like to check tumor markers too close to a laparoscopy because they can be somewhat elevated just from the irritation of the peritoneum. So the question that was asked though is, can tumor markers be normal, and then I'm assuming something like a CRP or an ESR be elevated? I'm sure that can. I'm not sure how to necessarily interpret that, but I can imagine that would happen.
Thank you.
All right.
Oh, Anne, did you want to say something?
Hi, Dr. Dineen. You met me last month. I'm one of your new patients, so just wanted to say hello.
Hello.
It's good to see your complete face because obviously.
Oh, that's right. We've probably only met with masks on, right?
Correct. This was me.
Yeah, that's right.
So
yeah.
I appreciate the talk because number one, thanks to this group, I'm now seeing you, and Dr. Virapong obviously referred me to you also. And now that you've given the talk, I've written down a ton of questions to ask you when I see you in October. So this is going to come back as a quiz, just to let you know.
Okay. I guess I need to be consistent then, right?
We'll see when it comes in terms of my records. But so I just wanted to say thank you. I appreciate your help with everything, and especially with my case. But I'm grateful for this group, and you asked me who my supports were, and you're meeting my supports amongst other people. So, and you said this is a fabulous support. You just certainly support it, and obviously you're here, so I see that. So, just wanted to thank you again. So I'll see you in October.
Well, thank you for that. Yeah, we'll look forward to seeing you. And this is a great group. This is a good group. That's very supportive.
100%, yes.
Well, and Dr. Dineen, you'll hear and find that we've been doing this since 1998. Our founder, Gabriella Graham, started PNP Pals, and many of us on the call are here because of the work that she did to help get us to care, and we're continuing that work now. And I did want to take a second. I'm going to show something else because PNP Pals has been supporting patients for so long. There's a number of programs that we have that can help give you support in these challenging journeys. Right, we're on the Zoom call today, and so if you have questions during this presentation, you can send an email to zoom@pnppals.net. We are monitoring that right now, and Fairly, thanks for sending in your question. And so feel free to ask questions that way and continue to attend these weekly calls. We anticipate having physicians on about once a month, so we're really looking forward to that. The Bare Bottom Bears program, we will send you a free little bear with its own gown that goes through its embarrassing experiences just like we do. So I've got my bear, and many of us here have our bears, and so we hope you'll order one. If you have questions about anything, technical questions for the jargon that you're hearing or about any of the information that's being presented to you, you can always send an email to info@pnppals.net, and Adele will make sure your questions get answered. If you have technical questions or more detailed questions, Arthur Reddick is a retired pediatric surgeon and a PNP patient. And so he loves to answer questions, and so you can send questions to him. He's always there to help. One of our most popular programs is the Get Well Cards program. We will have PNP patients from around the world send cards to you at appropriate times. If you're starting chemotherapy, that might be a great time to request cards. If you're going for HIPEC, that might be a great time to request cards. But we're here to support you, and you'll never forget the wave of love that you get when you receive those cards. And then finally, for the new folks here, we'd really encourage you, send an email to starterkits@pnppals.net, and we will send you a starter kit that's got important things like a notebook for you to take some notes and other things you're going to need along the journey, like antibacterial hand lotion as well.
Yes.
So I have those PNP Pals notebooks. I've used probably 2 or 3 of those. One's on my desk in the office right now. And just over the last weekend, we were out, and the hand sanitizer that I pulled out was a PNP Pals hand sanitizer. So
Great.
starter kits are great.
That's great.
Great. We do have some more questions. So one of the questions we received, what does HIPEC do to the intestines, and why are there so many bowel obstructions post-HIPEC, CRS HIPEC?
So the first part, HIPEC itself, in general, doesn't have a real harmful effect on the bowels. The heat can probably contribute to an ileus, which is kind of slowing down of the intestine or slowing down the gut motility. The extent of the surgery, so the cytoreductive surgery part, often almost always involves a greater omentectomy or removing the omentum. So that's the fat that hangs off of the stomach and the colon that everybody has. As you take that off of the stomach, though, you're also taking some of the nerves related to the emptying of the stomach. If there's also disease on what we call the lesser curve, essentially the other side of the stomach that you have to remove, then you have frequently taken out a lot of the nerves or injured a lot of the nerves that go to the stomach. So the stomach is frequently the slowest part of the gut motility to return after HIPEC. And so that can be why for many patients you have to have an NG tube for several days afterwards, is because the stomach doesn't empty very well. The reason for the high rate of bowel obstruction is probably most related to the extent of surgery. So the amount of surgery that's involved, again, can be quite extensive. And especially if there's a lot of peritoneal stripping or removal of a lot of the peritoneum, then there can be some scar tissue that is associated with the bowel and the abdominal wall. The normal function of the peritoneum is kind of to act as a lining and almost as a lubricant, so that the intestine, when it hits the abdominal wall, there's a smooth surface there so that it doesn't get stuck. So when you remove that, you can sometimes increase the amount of adhesions or scar tissue. And so that's probably the reason for the high rate of obstructions is most related to the extent of surgery and the surgery that's being done. I think there are some patients where the HIPEC, and we expect a little bit of this, the HIPEC alone, so the chemotherapy causes an irritation or a kind of a sclerosing type reaction. And so that can also contribute some. But I would say we don't know fully what the difference is. But in some patients that have minimal surgery with HIPEC, the incidence of bowel obstructions is not as high. So.
Thank you. Another question, we had heard from another specialist that sometimes the mucin gets reabsorbed. So the question is this possible, or is it very rare? Is it mostly with low grade? And then part two, how big does the spread have to be before it's visible on a CT?
So the second part is maybe more straightforward. Typically, we'll talk about a nodule being 1 centimeter before it's reliably picked up on CAT scan. You can certainly see smaller areas occasionally, but usually about 1 centimeter. The problem with peritoneal disease, what I typically use is the example is it's like a postage stamp. And so it's stuck onto the surface. And so even if it's 2 or 3 centimeters wide, it's not very thick. And so that's why it can be hard to pick up peritoneal disease on imaging. And so as it starts to get to be 5 millimeters thick or even bigger, that's typically when we'll start to see it on CAT scan. So if you're thinking about something that's kind of nodular, like a lymph node, it's usually somewhere around 7 millimeters to 1 centimeter in size. When we're looking at peritoneal disease, we're thinking about thickness. So it's in that same kind of range, but it's got to be much thicker, and that would be fairly extensive peritoneal disease when it gets to be that thick. Mucin is fluid, and mucin shows up in not necessarily as discrete, and so it's harder to define kind of a measurement, but probably in that same range is once you start to see 1 centimeter or so of thickness, you'll reliably pick it up. So the first part of the question. So acellular mucin, which is again that lowest grade of mucin, can occasionally be reabsorbed by the body. And so there are instances of low grade disease where, especially if it's shortly after surgery and you get a CAT scan, you may see a couple pockets and that may get absorbed over time. Less common if it's higher grade disease for that to happen.
Thank you. What would your recommendation be on timing of a third HIPEC? Is it advisable to wait as long as possible or to do intervention fairly early?
I think that's a great question. So the answer to that is that we probably don't know, specific answers to that. I think that the timing of when to do repeat HIPEC is hard. I've got some more slides about some of the specifics that we've looked at. But I would say that for a third HIPEC, I'd say personally, we would probably wait to see what the progression of disease is. So we wouldn't do it as soon as disease has been identified, but if it started to look like the rate of progression was increasing, we would maybe consider it at that point. It may also be a role for tumor markers. If the tumor marker levels are relatively flat or, just increasing a little bit, then again, that may speak to a slower rate of progression. Whereas if the curve is pretty steep, then you might start to think about it at that time.
Okay. Do you have an estimate on how many percentage of patients that require a second HIPEC?
So in our data set that we looked at, it was right around 10%. And I think if you look at other groups that have looked at that, it's in that same range of around 10%. Now, that's patients that have undergone repeat. Identifying kind of the whole group that would maybe be candidates for it is a little hard because of the nature of the way that we've done those studies.
Gotcha. Do you have any thoughts related to HIPEC?
So my experience with EPIC is not as robust as some others. I think that it is I think an interesting adjunct if given. So I think that the combination of HIPEC and EPIC is interesting, meaning you do the cytoreductive surgery HIPEC, you leave a catheter, and then you give additional intraperitoneal chemotherapy afterwards. So that's the approach that we use for peritoneal mesothelioma frequently. My experience with EPIC and kind of my understanding of some of the literature would suggest that it does contribute to kind of a longer stay in the hospital. And I think that conceptually there's some maybe questions about whether or not the distribution of the chemotherapy is the same. So we know at the time of surgery that our catheters are in and we get pretty good distribution of the heated chemotherapy. And the question when you leave the catheter in is how quickly does scar tissue or intestine kind of block off the fluid. We should get a pretty good answer to that question, hopefully in the near future from the study that is being conducted out of Memorial, looking at that question basically of HIPEC versus EPIC for appendix cancer.
Thank you.
So I see one more question.
Yeah.
How about if we read that last question, then we'll go back to the presentation. This question is from a patient who's not a surgical candidate. They've become aware of a trial using a virus to attack the tumors by Dr. Patel at UCSD. The question is, are you familiar with this study? Apparently there's other hospitals participating. It's a scary prospect, but the patient's considering it, and just wondering what your thoughts might be on that particular modality of treatment, Dr. Dineen.
I'm not familiar with that study. Sorry. I think that UCSD is a great institution, and I do know some of the surgeons that work there who I think highly of. Yeah, I don't know the details of it, so I don't want to speak too much, but oncolytic viruses have been used, and I think have been used successfully. So I think that would be, a discussion that you'd want to have with the clinical trial coordinators and obviously the person running that. But I think that in the setting of patients that are either not candidates or their disease is not amenable to surgery, that a clinical trial consideration would be appropriate.
Great.
Great. Okay, maybe we'll get back into the presentation.
Great. So we've started to talk a little bit about the role of repeat HIPEC, and we looked at, so at Moffitt, we're part of a group that we called the US HIPEC Collaborative. It was 12 institutions, all experienced centers, and our question was pretty relevant to some of the discussion that we started here. What are the outcomes associated with repeat cytoreduction? So I think if we go to the next slide. So we looked at a patient cohort that was about 2,200 patients, and essentially wanted to try to get a sense of what are the outcomes associated with that. You can see this is our first table, and it's a little bit busy, but if you look kind of in the middle, let's see, the second column, so the initial CRS HIPEC column there, about 63% of the patients had appendiceal cancer, whereas in the repeat HIPEC group, which was 158 patients, that percentage increased to almost 80%. So what that tells us is that patients with appendiceal cancer are more likely to have a repeat operation than from other histologies. And that's probably due to both patient factors and the disease being, in general, less aggressive than some of the other modalities or the other histologies listed there. But otherwise, most of the other other demographic factors were pretty similar between our two groups. So most of the discussion about this data will be between the initial CRS HIPEC, or the patients that just underwent their first operation, compared to the repeat group. So if we look at the next slide, the preoperative characteristics, including the extent of tumor marker elevation and comorbidities, were similar. The operative characteristics were also pretty similar, but one of the things that has been a point of discussion is whether or not, if you go back for surgery a second time, are you going to be able to achieve a complete cytoreduction? And we've talked about why that would be an important consideration. We want to achieve a complete cytoreduction. Some of the questions that we talked about highlighted some of the concerns, which is when I go back for a second operation, is there going to be so much scar tissue that there's just no way to be able to clear everything out? So what we found is that the rate of complete cytoreduction was a little bit lower than the initial operation. You can see there almost 90% at the initial surgery compared to 83% for the repeat. So it is a little bit lower, but 83% is still pretty good. So it's still pretty common that we'll see a complete cytoreduction after the repeat surgery. Let's do the next slide. These are post-operative outcomes. So length of stay, intraoperative mortality, readmission rates, I think even non-home discharge rates are all pretty similar between the initial group and the repeat group. The rate of any complication is similar, so not significantly higher in the repeat group. The overall rate of complications is still pretty high, so it's close to 60% of having, you know, any complication, but not difference. Sorry about the typo there, but the rate of severe complications is also not different. What we did see was that the reoperation rate was higher. So if you look at the repeat group, the need for a reoperation was close to 15% versus 9% for the initial group. So that was one difference that we saw there. Next slide. All right, so the question that everybody wants to know is, you know, is there a survival increase associated with the repeat operation? And that was a really tricky question to answer for various reasons. So the entire cohort that we looked at did include patients that had cancers other than appendix cancer. So when we looked at everybody, we saw no real difference. But when we looked at appendix cancer patients more closely, and we felt like since the majority of the patients that had repeat surgery were appendix, and we've talked about how important it is to understand the biology of the cancer, that if we just focused on appendix cancer, it would be easier. And it was, I guess, a little bit easier, but it was still a little hard. So let me see if I can explain these. If you look at the figure there on the left that's labeled B, this looks at all patients with appendix cancer, and it compares the group that had no repeat HIPEC from the time of their first operation to the group that had repeat HIPEC from the time of their second operation. And you can see that there's no difference there. If you look at the blue line and the gold line, they're essentially overlapping. But this highlights one of the issues that we have when we're trying to compare this data. And this is, again, all retrospective data. So we're pulling it from charts, you know, up to 10 years back. And so the difficulty here is kind of where do you start the time frame from? So what is the time frame that we're interested in? So one way to look at this is that the survival after your repeat HIPEC is very similar to the survival after your first HIPEC. And so sometimes we describe the HIPEC or surgery for this disease as kind of resetting the clock. So we'll go in, we'll clear everything out. We, in many cases expect that it may come back, but hopefully that we have delayed the progression. And you could look at that curve and say, well, that's about right. You have your first surgery, you get, whatever the time frame is, 4 or 5 years from that. and then you go back for your second surgery, and we would expect to see the same thing, same amount of time. So that's one way to look at that. But the problem here when we're comparing these groups is that in that no repeat group, there's a lot of patients that wouldn't really be candidates or qualify for a repeat operation. So those would be patients that didn't recur. So if you don't have recurrence of disease, then you don't need a repeat operation. Or the other big group would be patients that are probably just not considered candidates for usually other health reasons for a repeat operation. So the groups maybe aren't well matched for this comparison. So if we go over to C, which is the curve there on the right, this is a group of patients where in the no repeat cohort, the patients that we identified all had progression of disease. And so now we're comparing a group of patients in the blue that had progression of disease without repeat surgery to the group in the gold that had progression of disease and did undergo repeat surgery. And this is again, all appendix cancer patients. And you can see there that there is a difference in their survival. And so in this instance, it does appear that the repeat cytoreductive surgery has a benefit in survival, with the gold curve showing a higher overall survival than the blue curve. This does include all histologies. So in both groups, there's the low grade and the high grade tumors. But due to the relatively small numbers, we kept those together for this. So next slide. When we looked at what we call the multivariable analysis, so trying to keep other factors controlled, we saw that actually the repeat CRS HIPEC did not necessarily predict a longer survival. The things that predicted improved survival are the ones that we've talked about already. So the completeness of cytoreduction and the histology. So the poorly differentiated tumors did worse than well differentiated tumors, and patients with a complete cytoreduction did better than those that did not. So the way that we interpret this overall is that there are multiple factors that are involved. I think if you go to the next slide. So the limitations of this is retrospective. We did have a large database, but there was some missing data that we had to control for. And one of the things that was difficult with the specifics of this database is that we couldn't link the initial operation and the repeat. So we knew the patients that underwent repeat surgery, so we knew if that operation was a redo, but we couldn't, because of the way that it was de-identified, link that entry to the first operation. So one of the important things that we couldn't do in our study that's been looked at is what's the time frame between the first operation and the second. And so this is a study from the group in Australia that looked at the interval between the first and the second. And if it was greater than 18 months, the survival was much better. And so this is, I think that this was appendix cancers as well. And if the interval between the surgeries was less than 18 months, it was potentially still indicated, but the survival was less. And there's similar data from the Wake Forest group. I think they used a cutoff of 2 years and showed again that if the interval between the first and the second operation is longer than 2 years, that the survival is improved. So that was the limitations of our study. The next slide. So we took from this that repeat cytoreductive surgery in HIPEC was not associated with really significantly increased complications. So in some ways, it's a similar operation the second time around to the first. I either overlooked it on the slides or I somehow left it off of one of the slides. But one thing that we did show also in the repeat group was that the risk of a stoma was higher the second time around. So the need for either an ileostomy or a colostomy was increased to around 20% for the second operation. So it's a little bit higher than the first time around. And so that is one thing that I'll counsel patients on for redo is that the likelihood of a stoma is a little bit higher. The rate of a complete cytoreduction is slightly less than the first time around, but it's still about 80%. And we think that the interpretation of the data, that comparison of the group that had progression of disease without second surgery versus the group that did, appears to suggest a survival benefit. But a lot of this is going to be due to patient selection, and so it's hard to make that definitive comparison. Next slide. So we concluded that you should not really be concerned that complications are going to be prohibitive, and that you should discuss repeat CRS HIPEC for well-selected patients. One of the questions earlier talked about the timing. I still really struggle with that. I don't think that we have great data to guide sort of when to consider the first repeat, and certainly, as the question asked, when we should think about maybe a third time. I would say our practice tends to be what I outlined there, that we don't think about repeat surgery at the first sign of recurrent disease or progression. We tend to look to see what the rate of growth is. And oftentimes it can be relatively slow. And I would say, to maybe even take one step back, many times the first or second CAT scans will highlight areas that may be considered recurrent disease. I'm really cautious about some of that, especially along the liver where there may have been extensive surgery. We'll see a lot of postoperative changes that sometimes radiology will call questionable or possible disease. So I'm usually pretty cautious about, especially the first couple scans, calling anything recurrence. And then our approach, like I said, is typically to see what the pace of progression is. When the tumor markers start to go up, or when you start to see a significant difference between 3-month CAT scans, that's probably when we'll consider it. Next slide. So again, I think we'll pause. Let's maybe go to one more slide. Yeah, so I think I'll take whatever questions you've got, and we can spend time doing that. And then one of the things, if we have maybe a few minutes for, this is a study out of MD Anderson. Brian Badgewell's done some great work on looking at outcomes from bowel obstruction. And this is a recent one where his group just talked to some patients about what they thought was important in terms of what's a good outcome if you have surgery for a bowel obstruction. And I think our group at Moffitt, we're very interested in trying to look at what patients think good outcomes would be from cytoreductive surgery and HIPEC, and especially in the context of unresectable disease. What would be considered an improvement in quality of life. So I think the next slide, which I think might be my last one, is from this paper, and it just highlights some of the symptoms that this group looked at with bowel obstruction. And so maybe I think a reasonable overlap with some of the symptoms that patients with PNP may have. So I think if we go to the next slide, that's the end, if I remember right. And we can stop and I'll take questions and get maybe some insight from this group as to what are the important questions we need to ask and look at, and how can we make patients' lives better.
Well, we had a couple of other questions come in. So one question, if the cancer did not appear on the small bowel in a CAT scan, but was visible by the surgeon during CRS, is it likely that chemo, if previously fairly effective on the tumor outside the bowel, would be effective on the bowel so as to proceed with CRS at a later date?
I think the answer is yes. So that scenario where we don't see disease on CAT scan, but we see it at the time of surgery is very common. So that's a pretty common presentation. In some instances, we will do laparoscopy to look at the extent of disease. So laparoscopy, just small incisions, we'll put a camera in to look around. And that's, I would say, well, I guess I can't speak for everybody, but in my practice, I typically reserve that for high-grade disease. And so for patients that have poorly differentiated cancers, we'll frequently do a laparoscopy just to check that, to see if there's involvement of the small bowel that was not seen on CAT scan, because that is pretty common. Somewhere around 10 to 15% of the time with a laparoscopy, we'll determine that the extent of disease is too much, and so we won't proceed with HIPEC. So the question about chemotherapy is a little tricky. That's going to depend a lot also on the grade of the tumor. Our practice for low-grade tumors, we tend not to use a lot of systemic chemotherapy for low-grade tumors, more likely to use it for high-grade tumors. And if the chemotherapy was effective at the imaging that you could see, or if the chemotherapy was effective at treating the disease that you could see on CAT scan, you would assume it would be effective everywhere. But it is difficult to measure those, very small lesions on the small bowel. You won't typically see those on CAT scan.
Another question, many of our patients are told they need to have systemic chemo before the, CRS and HIPEC can happen. Is there, can you talk a little bit about the timing of that, or the art of that, of when the systemic chemo needs to happen before CRS HIPEC?
So I think that for our group, we again tend to be surgery first for low-grade disease, and we would reserve systemic treatment for after surgery if necessary. The instances that we would use it are typically in patients that have had an incomplete cytoreduction. For patients with higher grade disease, we would usually use chemotherapy, and our approach has varied a little bit, but probably we'll do 3 months of chemotherapy before surgery and then consider additional chemotherapy afterwards. Those decisions are really dependent a lot on the histology and how aggressive the tumor is. So, signet ring cell adenocarcinoma, we will usually do upfront chemotherapy for at least 3 months. And depending on the extent of disease, maybe even longer. Those are the patients where you really want to kind of make sure that there's not going to be progression of disease elsewhere before they undergo HIPEC. And so that would be one group there. I think that I think the discussion of chemotherapy, in my opinion, highlights the importance of having a surgeon on your team. I want to be diplomatic about how to say it. But, if you're seeing a medical oncologist, they know chemotherapy. That's sort of what they do. And so the recommendation will frequently be for chemotherapy. And so I think getting just to a center that sees appendix cancer, most of those are going to have a surgeon that's involved in the treatment team, I think is helpful.
Yeah, totally agree. I mean, I think your presentation really highlights the importance of seeing a specialist and what a difference that can make.
Yeah.
Do you have some thoughts, or could you comment on how many CRS HIPECs can one patient possibly go through?
So I think that I have heard a group who did 9 on a patient. 8 or 9. I guess those were, I think 2 were in the chest. So maybe only 6 or 7 abdominal surgeries. I mean, I guess that would be an individualized decision. I think most studies that look at the iterative or the repeat HIPEC have gone up to 4, and that group that had 4 was very small. I think single digits in terms of the numbers of patients that had that. So I think that it's reasonable to consider the second HIPEC, probably reasonable to consider the third HIPEC. After that, I think I would go back to that maybe last point I was making. If it's, first HIPEC and then 10 years later you have your second, and then 10 years later you have your third, maybe it's reasonable to consider doing it again. But if it's starting, that gap between surgeries is starting to get narrower and narrower, then I think you have to start really wondering if it's worth the operation at that point. But I'm sure that people have, like I said, I know for a fact that there was a presentation of a patient that went through more than 4. So my personal,
Yeah.
I have done a 3rd time HIPEC, and that's all. So other questions?
Any
Question, Dr. Dineen. So does scar tissue change over time? Like if that gap between the first and second treatment, right? Does scar tissue change over time? Let me just ask that question.
It softens over time.
Okay.
And it may not ever completely go away, but the longer that you can wait between operations, the better.
Okay. So, I mean, in some ways, it's almost a strategy of, stretching out that time between HIPECs as much as possible without it getting so advanced that, the small bowel and mesentery get involved, and the HIPEC, then becomes not so much an option.
I think that's a great way to say it.
Okay.
Well, and we've learned too, as time marches on, there are more and more advances, and their patients have more and more options too. That's
right. Yep. I think that's also, a great way to think about it. That we're trying to just basically extend survival, and who knows what's going to be different 5 years from now than right now. True.
And I know those of us that have been on these presentations, and as a patient, when you see survival statistics, it's hard to not personalize it, but it's important for everybody to remember, as you had pointed out, some of the data is old data, and it's information. It's not necessarily the individual, but it's information, and it's just a piece to think about. But each case is different.
Right. I think that's a great point. And it's hard. I think it's one of the hardest things to figure out the right way to do is how to talk about survival. Because I think it's important that patients understand sort of what they're dealing with. So you want to give context. But to your point, survival data is an average of hopefully thousands of patients. So to get a good number, you need a lot of patients. You take an average. That means that half will have survival less than that, and half will have survival longer than that. I never want to be cavalier about survival, but what matters to the patient is it's either a 0 or a 1, right? Like it's either you're alive or you're not. And so it gets to be tricky. So I think that interpreting this survival data to an individual level is very hard. And I think it should be considered as a context for how aggressive the cancer is. And I think that's a great point.
Yeah, and so we also talked to amongst our group, the emotional resilience of this journey for each of us is not to be underestimated. And so we have our good days and our bad days, but it's a journey. And so that's where we like to think our group works in tandem with the medical professionals in terms of supporting the patients and helping with that hope and that emotional resilience.
Yeah, I think that, another great point. The extent of this operation, I think the length of time that patients are in the hospital, the recovery from the operation, really, it is a journey. It's a long process for both the patient and the caregivers. You know, I think harder now that at our hospital, and I think most, you know, you're by yourself. Nobody's allowed to be with you. So I think that's a really tough, it's a really tough time to be undergoing this operation. And so, you know, I think one of the interests that we have is trying to really outline that patient journey so that we can give patients some of this information to either take home or to have available. It's just, I mean, it's tough to convey all of this in a 45-minute meeting. And I think I will pause for 1 second. I think Danielle Laskowitz was on the call. She's a PA that works with our team, and I'll just give a shout out to her if she's on the call, because
Yeah,
we have a great team, and while I get to have the privilege of talking to you all like this, you know, I can't do this by myself, and so we have a really good team.
Hi, Danielle. Thank you for
Hi there.
joining.
Yes, thank you. It's really great to be able to reach out to all these patients, especially on this platform, be able to discuss with them, you know, a little bit more in detail, sort of what we do and everything. And so it's great to be able to work at Moffitt and be able to help with all these patients. And it's been such a great organization to work with as well.
Thanks, Danielle. Sorry to put you on the spot. I'm sure I'll be in trouble for that later, but
That's okay.
Yeah, another question that came in, if the cancer is not visible from the CAT scan, but we know it's there, why couldn't it just be, you know, immediately removed?
if it's not visible in the CAT scan, but we know it's there, well, so I mean, you'd have to then consider. So I guess that would really depend on the location. So I guess I'm trying to think about the scenario where that would probably come into play is like I was talking about. You don't see anything on CAT scan, but maybe you've done a laparoscopy and you've seen tumor, or you had an appendectomy, and at the time of the appendectomy, they saw mucin outside of the appendix, but then on the follow-up CAT scan, you don't see any. So I think both of those issues would then depend on the grade of the tumor, and then it would depend on what the extent of disease was. So frequently we'll see a small amount of mucin that's reported on an op note from an appendectomy, but we don't see anything on CAT scan. Typically in that instance, I think that the need for surgery is very low, unless it's a high-grade tumor. But in most instances, that's just acellular mucin, and that would be a scenario where we would watch and expect a very low rate of progression. The other scenario is that we don't see cancer on the CAT scan, but we've done a laparoscopy and we've seen a lot of tumor. And that would then just be, to me, a question of the grade of the tumor and the extent of the disease, because if we had done that, then I think in most instances, we probably would think about surgery, if I'm understanding that kind of scenario or question, right?
And let me try and elaborate, because I think part of what the question is when the small bowel does start to get involved, I imagine there's a spectrum of that involvement. You might find 1 or 2 nodules, and perhaps those can be removed. But obviously, as there's more and more involvement, right? So how do you think about that, Dr. Dineen? How do you think about approaching that, and when to disturb the small bowel and when not to?
Yeah, so good question. So at the time of surgery, assessing the small bowel is an important part. And if there's, you know, a handful of small areas or small lesions, we'll take those out. You can typically do that kind of in a similar fashion, where you remove it kind of off of the peritoneal lining of either the mesentery, which is the fat that covers the blood vessels, or the lining of the intestines. And, you know, you can usually remove it without having to remove the whole portion of the intestine. So we'll try to address as many of those areas as we can. And As you alluded to, there's a spectrum as you start to get more and more tumors, or as the invasiveness starts to increase. So if you have a lesion that's invaded into the wall of the intestine, then you have to remove a portion of that intestine, and either, sometimes you can remove a small spot and then just suture it closed, but more frequently you'll have to remove a segment of the intestine and then sew those back together. So you want to be somewhat judicious about how many connections you make. So each connection has a risk of leaking, and that can be, that's a pretty severe complication. So you want to be somewhat aware of how many of those you have to do. And then you have to be aware of how much small intestine you're leaving behind. So you want to make sure that you're not removing so much intestine that patients aren't going to be able to absorb calories. We would call that short gut syndrome. And so those are the things that you have to be considering at that time. Usually when we talk about tumor that's involving the small bowel to the point that it's unresectable, one of two things has happened. Either the entire intestine is covered and you can't take out all of that and leave the patient with any quality of life, or the mesentery is covered. And what happens when the mesentery gets covered is that it starts to contract and it really shrinks up. And when that happens, the intestine becomes kind of like so we call that cauliflowering. It kind of looks like that. And it isn't mobile. So you can't move it at all, and you can't separate it to be able to remove anything. So those are typically the instances where we'll say that the disease was unresectable.
And then perhaps the medical oncologist has a greater role at that point in time.
Right, that would be an indication where we would typically start some form of systemic chemotherapy. That's right.
Yeah. Good. Well, and I think, talking to the group, this is again it speaks to the importance of having a team of physicians. I've been doing this for 16 years personally. I'm a 16-year survivor, and I learned something new from every presentation. Today is no different. But there's many physicians obviously that are on my team, and I continue to consult with medical oncologists, surgical oncologists, and so it just speaks to the importance of having that broad team. And we'll reiterate that in our experience, the specialists and most local physicians too are happy for us to get second, third opinions and become educated and seek alternate opinions. And as Dr. Dineen said earlier, right, often when you go to a specialist, if you go to a medical oncologist, they're going to talk about chemotherapy because that's their expertise, and they will often make recommendations around that. If you talk to a surgical oncologist, they may seek surgery first. So it does become incumbent upon us to be educated and make those decisions for ourselves and decide what's the best approach to take. I always say here in the US, we have access to the greatest care in the world, but we have to also carefully consider what we do or do not choose to do from a treatment standpoint. We ultimately are that single point of focus, and our physicians can help us make decisions. We have to decide what care is right for us at the end of the day.
Yeah, I mean, I would reiterate that. I mean, I think of our team as, our role is to do things like this, but to basically help patients understand what they're facing, help them understand what the options are, the risks and benefits of that. In situations where I think that, one option is clearly better than the other, then I'll say that, but it's a discussion and ultimately, a shared decision, but the patient should be the one that gets to decide. So.
Right. Yeah. We didn't have any more formal questions come in, but if anybody has any other, just raise your hand. Yvonne, do you have a question? Okay. We have to unmute you.
There you go.
I have a question. I had my first HIPEC in 2005, and I had a recurrence in 2016. So almost 12 years I was evidence-free. I had my second HIPEC in 2017, and now there are some spots again, and I would hope that I could get a third HIPEC, because after the second HIPEC I was recovered quite soon, and it went very good. But I have a lot of scar tissue, and my PMP is hardened on my stomach and a few spots. So my specialist, he thinks we should wait and watch, or I could start with to try if Avastan could do something. What is your opinion about that?
Well, I mean, I think that gets back to kind of the question
I have
of,
low grade.
of
I have low grade.
timing. Yeah. So, I mean, I think that would depend a little bit on some of the specifics of your CAT scans and disease. I think that, you know, I would probably just sort of reiterate what I'd said. We would probably look at the pace of growth with that one. And your surgeon probably has a great understanding of sort of what to expect with regarding the scar tissue. And so I would make sure that you just get their insight into how to do that.
So no third HIPEC, or?
Yeah, I think that would be, again, a pretty individualized discussion, and it would depend on review of where the specific cancer spots that you're talking about are. Sometimes if they're near the stomach, then that can increase the morbidity of the surgery, meaning you may have to have a big part of your stomach removed. So I think that gets back to kind of one of the limitations of the study that I was talking about. Your surgeon will know where there was difficulty, either tumor left behind at the first one or where it was hard, and have a good sense of whether or not a third time will be successful. And so I think that's where the patient-specific stuff is kind of hard to talk about.
Yeah, and what do you think about using Avastan?
Avastin? Yeah. So I mean, as a chemotherapy choice, we use Avastin. So we would usually for chemotherapy, we take recommendations that are similar to colon cancer. So we use 5-FU based regimens with Avastin would be common for us.
But I'm afraid of Avastin because when something happens, you are not able to get an operation because the wounds don't heal when you use Avastin.
That is a consideration with that drug. Yes, ma'am. So,
yeah, okay.
Yep.
Thank you. It's difficult.
It is. It's tough.
And so, Yvonne, I think in your case, this is one of those places where, opinions from other physicians might help. I think for Dr. Dineen or for other physicians to make an educated and informed, give advice, they need to see
Yes.
records. So they'd have to see images and reports and maybe even speak with the other physician who's treated you in the past. And different physicians are willing to take different approaches. Just as a medical oncologist might give very different advice about treatment, within the surgical oncologist, there's a spectrum of aggressiveness there too. And so, but you're right, there's pros and cons to each of our choices. And that's where we just have to balance those out for our individual self.
Yeah. Thank you.
Yeah, you bet.
Thank you very much.
Yeah.
We did have another question come in. Can you have HIPEC without having surgery if you're not a surgical candidate?
So the answer is yes. So you can do HIPEC separately. So the difficulty then becomes kind of the approach in terms of how to do it. And then some of the details about sort of why you're not a surgical candidate. So I think an area of interest for our group, and I think for even a wider group of surgeons that do this is what is the best treatment for patients that we would consider unresectable from a surgical standpoint. So the scenario that I was describing with small bowel that we can't clear, for example. we don't know what the benefit of HIPEC or potentially HIPEC followed by EPIC is. So I think that's a question that we would like to answer. But I guess if I try to focus on the question, you can have it. It's unclear kind of what the benefit of that would be if you have unresectable disease. And in some patients, the extent of surgery that they've had before would make it difficult to do a laparoscopic HIPEC. But usually in the situation where we're just doing HIPEC, we try to do it through a minimally invasive approach. And the most common reasons for that are going to be patients that have a lot of ascites, and usually that's non-mucinous ascites. So that's the thin ascites. And so we'll try to do HIPEC for that because sometimes that can slow that down. Or there's use of laparoscopic HIPEC in gastric cancer now. So.
Thank you. Okay, we are close to our time, but if there are any other questions. Now, Connie, did you have?
Hey.
Hi, Dr. Dineen. Thank you for coming on. This information has been extremely valuable. There are a few individuals on the call that are newly diagnosed. What would be your recommendation for the questions that need to be posed to the appendix specialists? You know, they've been giving all this other information and they have the deer in the headlight look. Because it's so much to take on. What would you recommend the key questions to ask when you are coming to yourself or your colleagues that are vital with this rare disease? You know, that's something that I see in other individuals that we speak with. So I'm interested on what you have to say about those questions that are key elements in dealing with this disease when you're newly diagnosed.
So I think that's a great question. I would say that so we've talked a lot about the importance of the pathology today. So I think it's a good idea to figure out who has reviewed the pathology. Is that at a place that has seen this, you know, frequently or not? So I think that's important. Patients will frequently apologize to me when they ask me how many times I've done this. And I think that's a perfectly fine question. So I think it's very reasonable to ask your surgeon or your team how often you see this. And so I think that those are both places I think that you could start in terms of trying to figure out if the center that you're at is what we would think of as an experienced center. Now, what are the specific numbers? So how many patients or how many of these operations do you have to do before you'd be considered to have expertise? I mean, I think that's a little bit unclear. But certainly you probably want to be at a place where your team is treating, you know, 20 to 30 of these a year, I would say would be a pretty reasonable low number. You know, 1 or 2 a month seems like a kind of a minimum in my opinion. I think the bottom line, and maybe we've kind of alluded to this a little bit already, you really want to trust your team. So you want to have, you know, faith that your team has a good understanding of this disease process, has the expertise both from a surgical standpoint, from a medical oncology standpoint. Again, I can't talk about my team enough and how important it is that that it's not just, you know, sort of one person doing this. I don't know. I think, did that answer your question, I hope?
Yeah, it's, you know, there's a lot of questions from those newly diagnosed. What should I bring with me? Do I need to bring my scans? What are those, you know, key questions that I need to, you know, they're essentially interviewing you.
Yeah, you have to have CAT scans. Yeah, so CAT scans are going to be key. So you need to make sure that your surgeon has CAT scans that are fairly recent, and I mean, I can't imagine a scenario where the surgeon would not have reviewed it, but that would not be right. Make sure that they've reviewed your CAT scan. And then they have to have pathology. So you have to have either pathology report, or ideally, I always have our pathologists look at the slides themselves, unless for some reason we can't get them. But that's I think, two key things are going to be the imaging and the pathology.
And then one of the other topics of conversation comes up. There are those that are seeing an appendix specialist, a surgical oncologist in this field, dealing with this disease, but then they want to seek another second opinion from another appendix cancer specialist. What are your thoughts with regards, and how do you handle that?
A second opinion. So my line, which is maybe not as funny as I think it is, but I tell patients, if you bring up the idea of a second opinion and your doctor gets defensive about it, then you definitely need a second opinion. And so I don't have any problem with second opinions. I encourage it. The only thing that I tell patients, kind of from my position, is that if you've been to Moffitt and you're going to seek a second opinion, you should go somewhere that's kind of worth your trouble. So I will typically recommend places that see more patients than we do. So so that's the only thing that I specifically do. But I mean, if a patient that comes to see me wants to go see somebody else to get an opinion, I will typically give them 3 or 4 names or institutions where they should go see, where I think that the opinion, again, is worth their time to go get. And, if they end up having surgery there, then I know that they're in good hands. So.
And Pamela, I'm looking for your screen. I'm glad to see you shake your head up and down, my dear.
Thank you.
Sure.
And I've unmuted Pamela if you want to make a comment, Pamela.
Well, thank you, Dr. Dineen, for saying that. I've had some experience with that particular issue of my position seemed rather offended that I sought a second opinion. So it's been a little disturbing, but.
And PNP Pals, our whole mission sometimes really is just to help get patients to the specialists, because we think that offers the best chance at long-term survival and thriving in life. So we're super excited that all of you are here, and we hope you hear that message. And the specialists really can make a difference. So super glad that people are getting the care.
Yeah, and thank you for saying that, Dr. Dineen, because there is that hesitancy, and people are, feel they're hurting the physician's feelings, but ultimately it's got to be about what's best for the individual and what's their comfort level. And it's educational to have more than one opinion. You learn a lot with each consult.
Yeah, I mean, that's completely true. And I mean, when we think about how much time we might spend into looking for, a new car, I guess that's not an unimportant decision, but, it seems not right to think that, in an hour or 45-minute visit, that if you want more information, I think you're entitled to it. So. And I almost never sign somebody up right away. So I'll almost always visit with people twice. So sometimes even at the first visit, we know that the plan is going to be for surgery. But if that's the case, then I'll typically have somebody come back a little bit closer to the time of an operation, just because it can be hard to get everything that we've talked about sort of settled in. And we still find even after that there's some things that we just didn't communicate well or didn't sink in. And so we try to do as much as we can to reiterate the points that we've made.
Well, and I want to reinforce for the patients today, as a patient and for the caregivers too, that we know it's a terrifying journey. It can be very difficult to hear the information and see some of these statistics, but really want you to know each case is individual, as Dr. Dineen said, and we have a ton of hope for you, truly, because there truly are advances happening every day. And while this is scary, you can get through this. We do encourage patients to get a therapist on their team from day one, and continue working with them on a weekly basis, and more if necessary, because the emotional challenge, we often say, is sometimes greater than the physical challenge. And this of one of the most physical diseases and challenges there can be. But truly, we see amazing things with patients with signet ring cell, having very long-term survival for decades. And so have hope and keep looking for insight and advice from different physicians. And I'll say, Dr. Dineen, I've truly gained a new appreciation for your patience and bedside manner. And I think it's fantastic that you take at least a couple consults with patients before signing them up for HIPEC. I think that's truly amazing. Yeah.
Absolutely. Sharon, would you like to say something?
Hold on, let me find Sharon here.
Sharon has an upcoming surgery soon.
There she is. Hold on. I had to find you, Sharon. There you go. You can unmute now.
Yep. You're still mute.
So Sharon, we can't hear you. You have to unmute yourself. There you go.
Sorry, I'm having surgery August 25th with Dr. Burnley at Stanford.
Oh, great.
And I think I'm fine with most everything. There's been so much information, it's very overwhelming. But I'm wondering what determines getting a right hemicolectomy. I see that people have it or they're not having it, or I think I saw a report with Dr. Sugarbaker and saying we don't need to do a right hemicolectomy. I mean, I don't know what that really means.
So yeah, so a lot of that depends. So the grade of the tumor again. So for higher grade tumors where we're worried that there may be lymph node involvement, then we'll take the right colon, because then you can check the lymph nodes. For low grade tumors, it will just depend on the extent of disease seen at the time of surgery. So if it's still tumor overlying the right colon or the intestine in that location, then that's when you would do it then.
Okay, thank you. That's all I really wanted to know, but I'm enjoying this broadcast.
I'm sure you're going to do great. That's a great institution.
Thank you so much.
Yeah, that's great.
Yeah, and to echo Chris's comments, we can't do our own surgeries, but we can participate by getting all the information, getting comfortable with our treatment plan, having that emotional strength, and then, having the support, knowing that you're not alone.
Yeah, been very helpful. Thank you.
Okay. And well, in closing, I'm going to share the screen just one more time and show you a few more ways that you can engage with PNP Pals throughout the week. We do have tons of information, blogs, and inspiring patient stories on pnppals.net. Likewise, on Facebook, you'll see these Hope Zoom calls scheduled as events, and so you can register through there or find out when the next one is going to be aired. Next week we will be doing the round robin support group, and we'd encourage everyone to come and just talk about how you're doing. We're here for emotional support. We find that information empowers and inspires patients, and so we're happy to share our knowledge and experience with you. And so we hope we'll see you next week. And then finally on Instagram, you'll find us at PNP Pals with an underscore in there. And we hope you will engage with us there too. Feel free to comment and like us, and we hope you'll visit often. But I will say it, I say it every week, this is the highlight of my week. And I'm so glad that everyone's come, and we enjoy seeing you. So we have a ton of hope.
And Dr. Dineen, thank you so much for spending, 2 some hours on a Saturday to be with us. We really appreciate the thought that you put into the presentation. It was very, very valuable, and we're happy we have this connection with you.
Yeah.
Well, yeah, thank you for the opportunity. It was great. And you know, I know that a few of my patients are on the line, so it was good to see that. And yeah, thank you.
I think with that, have a great week, everyone.
Thank
Thank
you.
you.
Thank
Appreciate
you.
it.
Thanks so much, everybody. Have a great week.
Bye.